طيب، بسم الله الرحمن الرحيم. مواصلة في المحاضرات الليلة عندنا ضيف يعني عزيز جدا جدا، دكتور مازن عوض. دكتور مازن عوض is currently a consultant psychiatrist في مستشفى الأمل في دبي. يعني he is really interested في like medical education, psychiatric leadership. عنده يعني he's been working in several universities حتى من السودان. كان شغال في Upper Nile University since 2008 وبعدين he joined البحري University 2014. He became the chair of the Bahri University in 2015. He's currently an adjunct processing professor في محمد بن زايد University في دبي. And currently محمد بن راشد University في دبي. And currently برضو he's a consultant psychiatrist في الأمل University. عنده a lot of interest in medical education. Today he's going to share with us an interesting topic واللي هو psychiatric aspect of epilepsy. بس قبل ما نبتدي المحاضرة برضو حبة هاوس كيبنج اللي هي أي زول يخش يعمل نفسه سايلنت. تاني حاجة بعدينك يعني نسأل مازن إذا هو عايز المحاضرة كيف عايز يقدم المحاضرة تقديم أول ولا يخلي فيه مشاركة في الهنا، يكون في حبة مشاركة في الأسئلة والأجوبة في نص المحاضرة. أنا أضيف ذات مازن. تفضل يا مازن.
طيب. السلام عليكم دكتور ياسر. أول حاجة يا أخي أنا سعيد جدا جدا يعني بالتقائكم، وسعيد جدا جدا بالاستضافة دي، وسعيد كثير شديد إنه أشوف يعني أساتذتي دكتورة فتحية ودكتور عبد الغني يعني منورين المكان يعني. وإن شاء الله السنة الجاية بإذن الله نكون آمنين في وطننا، وتكون المحاضرة في ربوع الوطن الحبيب إن شاء الله في مجلس التخصصات الطبية، المكان اللي بنحبه وبحبنا يعني. وتحية خاصة للزملاء واخواننا الداخلين من السودان، النواب القابضين على الجمره يعني. ياسر انا I don't mind to be interrupted، ما عندي اي مشكله، وعايزك برضو لو كنت انا too fast to slow me down، ولو كنت يعني too slow you can give me a push، ما في مشكله. الافضل انه يكون في interaction، وفي النهايه يعني لو عايزين اسئله في النهايه برضو I don't mind. تمام. طيب اذا الناس جاهزين we can kick on. طيب بسم الله الرحمن الرحيم. طبعا الطبيب هو سايكاتريك اسبيكت اوف ابيليبسي. انا في الحقيقه اخترت الموضوع ده. الموضوع ده اهميته في ثلاث حاجات بالنسبه لي. اول حاجه السايكاتري، طبعا الابيليبسي has been classified as psychiatric disorder for a long time by the way يعني before they discovered the medication. The patient they will have a lot of attacks of Caesar and they classified. الحاجة الثانية نحن برضو till recently لحد نحن كنا في training there is a lot of patients they came for refill of medication for epilepsy، وعندنا زملاء كثيرين جدا كان بيشوفوا cases for epilepsy، وانا كنت بتذكر especially the carbamazepine. يعني a lot of patients يمكن لحد الان يكون في جزء منهم بيجوا المستشفيات النفسية عشان يتلقوا الأدوية. الحاجة الثالثة طبعا there is a strong relationship between the epilepsy and psychiatry, there is no doubt. الحاجة الرابعة بالنسبة لي أنا كانت it's very important because أنا have been working in the liaison psychiatry for a long time. I saw a lot of patients with psychiatric comorbidity, a lot of patients with epilepsy. Suddenly I shift from Rashid Hospital to Amal Hospital, and the culture is different. Yes, يعني you know that when you work in a hospital, general hospital, your ears will be يعني responding to the code blue. يعني code blue في general hospital most of the time is a cardiac arrest. You will see the rapid response team come running. The patient will have a CPR. Most probably he will be taken to the ICU. When I moved to Amal, it was different. I was noted that code blue announced, and then all of a sudden the code blue finish. So I asked one of the nurses what happened. And code blue usually take long time, and he told me that code blue in an Amal sometimes it can be epilepsy. So I start to navigate the hospital that we are working on. So we have the intellectual disability. It's very common to have psychiatric epilepsy with intellectual disability. We have the old age psychiatric unit. So we have child psychiatry team. We know that epilepsy has bimodal time. It's very common in early childhood, and it's very common in senior citizen. I don't have any conflict of interest. This is completely scientific material. My objective, it will be touches in historical background of epilepsy, classification of epilepsy, etiology of epilepsy, comorbid, psychiatric comorbidity. This is a very important things, and assessment and management. Epilepsy has been discovered very early, يعني 4000 before the common era. It was written in the literature and recorded. But unfortunately, still it was discovered very early, but still fear, misunderstanding, discrimination, social stigma has surrounded the epilepsy. And the people with epilepsy and their family, they are affected by the epilepsy and it's affect their quality of life as well. This is Sekuku paper. It's a very old paper that they write about the epilepsy, okay, in table 26. So epilepsy has been discovered very early. I think all of you, you know Hippocrates. Hippocrates is the father of the medicine, and we know that the oath in the medical council, it's come from Hippocrates. So Hippocrates, he talked about the biological relationship of epilepsy for a long time. That we know that many things attributed to devil. So epilepsy has been attributed to the devil before Hippocrates talked about it. So Hippocrates said that men think epilepsy is a demon mainly because they don't understand it. But if they call everything as a demon, which they don't understand it, why there would be no end for the demon things? So till now, people, whenever they have something, they don't know what is the reason. They will say, oh, this is devil, this is shaitan, this is sihr, and this is jinn, right? So he the first one who talk about the biological aspect of epilepsy. This is how they treat the epileptic patient. They took him to the priest to be placed because they feel that the reason of epilepsy is diva. And this I took it from the internet. It is not an old picture. علاج مرض الصرع بالأعشاب. So they believe that traditional medicine can help in epilepsy. This is an old picture. I like it. It's very close to my heart. You will see Dr. Fawaz sitting down and Dr. Nahid. We visit outside for Sheikh Al-Tayyib Al-Jid, and we saw a lot of patients. They have been getting treatment in the Masjid. So it's very important to interact with the traditional healer. And a lot of patients, we love them because they go to traditional healer. Okay, again, Hippocrates also he the first one who talk about the relationship between epilepsy and uh, and psychotic disorder. He said that melancholic ordinarily become epileptic and epileptic melancholic. What determines the preference is the direction of melody. So if it take upon the body, it's epilepsy. If taken about the intelligence, it is melancholic. And we know that if you go to the conference now, they are talking about the bidirectional relationship. So they say that epilepsy it can lead to mental disorder, and mental disorder it can lead to epilepsy. And those who are they think is dimensional, they think that the origin of epilepsy and the origin of mental disorder is one. This is key fact. I took it from the WHO website, and it's very important. We know that epilepsy is chronic communicable disease of the brain, affect people of all age. So early childhood till the late age. Around 50 million of people worldwide have epilepsy, making it one of the most common neurological disease globally. Unfortunately, nearly 80% of epilepsy people, they live in the low and middle income countries. And you know, these countries, they don't have a service, they don't have doctors, they don't have medications. And I was mapping the Africa map. We have like 54 or 52 countries. 10 countries, they don't have one neurologist. And there is many countries, they don't have even one psychiatrist. So most probably this is a problem. And 70% if they have an access to the medication, they will be seizure free. I want to ask this question because it's very important. I want a volunteer. Did anybody hear about the SUDAP, terminology SUDAP, the registrars? Anyone can volunteer?
Again, what is the word?
SUDAP. SUDAP is sudden unexpected death of epilepsy. There is some patient with epilepsy, they can die without any reason. Some people, they think that if thought it's come at night, or it's like the prevalence is 1 in 1,000, which is not an easy number. And
الصوت بيقطع. مازن احنا we lost you. مازن
it will be a shock. So the patient and their family, they should know about this.
مازن, can you just يعني repeat what you said لأنه قطع الصوت قبل شوي ما سمعناك.
Okay, so the SUDEP is sudden unexpected death. Okay, sudden unexpected death of patient with epilepsy. It is very common, yeah, Dr. Yasser. It is 1 in 1,000. And when I give this lecture in the hospital, there was a debate. Do we put it in the consent? We shall educate the people about this one. It is very important. Okay. Am I clear, Yasser? ياسر سامعني؟
سامعينك.
ممتاز. طيب, this is from the Journal of Neurology Science. Why does Africa have the lowest number of neurologists, and why and how to cover the gap? So there is 10 countries, they don't have one neurologist. Okay, so there is a very clear gap in Africa. Okay, so why I choose this lecture, which is very important. What is the bridge between psychiatry and neurology? There is many things. The first one is the differential diagnosis. Any episodic disturbance of behavior or atypical attack of aggression, epilepsy can be a differential diagnosis. The first thing. They say the etiology that we know the temporal lobe is involved in many psychiatric disorders. The other thing, the treatment of the complication of epilepsy, it impacts the psychosocial life. They have a high degree of comorbidity, so they might need psychology intervention. They might need medical treatment, right? So the other thing, the seizure, we know that our medication, it can reduce the seizure threshold, and it can lead to the epilepsy or lead to the seizure, right? The other thing is the side effect of medication. There is many medication, many anti-epileptic, they lead to depression, they lead to an anxiety, they lead to irritability. I remember very well, I have noted that in Rashid Hospital, there is many patients, they became very irritable. So I asked my colleagues in the neurology department, if there's any medication, new medication, come register in the hospital. So I discovered that it was the Kepra. So we have many patients in Kepra, and they are very irritable. So the tool of diagnosis, epilepsy is diagnosis by clinical diagnosis for sure, but EEG, it helps you to diagnose. And if you do EEG for one time, 50% of the patient, they will demonstrate epileptiform abnormalities. But if you look to the other side, there is 50% of patients, they are not discovered. And we know that the neurologists, when they write the EEG report, they write a gold message that normal EEG does not exclude epilepsy. And this is why you have to do the EEG many times to at least to catch some of the cases. And there is also techniques to increase the likelihood of discovering the epilepsy, like sleep deprivation, photic stimulation, hyperventilation, all these done to increase the chance of recording the epilepsy, okay? And the gold standard of epilepsy diagnosis is the telemetry, that you video recording for the epilepsy, you have the EEG, and at the same time, you will see the movement of the patient. And this is gold standard, okay? And it's very good for the patient. If the patient is having ictal epilepsy, and you think this patient might have a psychogenic epilepsy, which before they would call it pseudo-epilepsy. I don't like the pseudo-epilepsy because the patient, they are not lying. It's psychogenic, okay? So the patient, if he is having a fit, and during the fit, his EEG is clear, most probably this is not a true seizure, okay? So to make anything, to diagnose any disorder, we have to know the definition, right? So the definition of seizure, it is sudden uncontrolled electrical disturbance in the brain, which can cause change in a behavior, movement, feeling, and the level of consciousness. And not every seizure is epilepsy. You might have one-time seizure, okay, and it will not recur again. You might have a recurrent seizure, but it has a very clear reason, okay, which you're not expected to have a repeated seizure. But the definition of epilepsy is defined as two unprovoked seizures occurring more than 24 hours apart. And this is from the International League Against Epilepsy. The International League Against Epilepsy, the first one was 1989, and the last one, it was released in 2017. So they make some change in 2017 definition. They said that you can diagnose with one sort of seizure if the likelihood is more than 60% of having another. So like you have the patient, he's having tumor in his brain, or his EEG was positive, or there's a clear reason the patient he will have a recurrent seizure. Okay, and the International League of Against Epilepsy is very important. You have to go and read about it. Okay. So what is the cause of epilepsy? We have to know the cause. If you want to treat, we have to know the cause. Epilepsy is not contiguous disease for sure, as you know. The cause in 50% is unknown. Okay, so we know that sometimes epilepsy, we don't know the reason. And the reason, it could be structural causes, it could be genetic causes, it could be infectious causes, it could be metabolic cause, it could be immunological causes. Okay, so the causes is different. So this is example for the causes like brain damage. It could occur prenatal brain damage, perinatal damage. We know that the loss of oxygen to the oxygen or trauma during the pulse or low pulse weight, the patient, they can have epilepsy. And we have a lot of patients with cerebral palsy. They are taking anti-epileptic medication, right? Congenital anomalies, genetic condition. So there is many genetic condition. They have a lot of epilepsy. Stroke. We know that stroke, it leads to restrict amount of oxygen delivered to the brain. So the patient will be on risk on getting seizure. Okay. Infection like meningitis, encephalitis, neurocysticercosis, certain genetic syndrome. All this could be a cause of epilepsy, but 50% is unknown. Okay. This is a case report. I don't know Dr. Mahash is here or not, but we did in the Rashid Hospital. We discovered a case of neurocysticercosis. And neurocysticercosis should not be in Dubai. You know, that is very common. By the way, it's very common in Africa, okay? And it's a parasitic infection by Sodium, okay? So you don't accept it, but Dubai, because it's multicultural country, we get this is a picture of the neurocysticercosis. You saw the brain, a lot of cyst, okay? And he presented with psychiatric manifestation before we discovered that the psychiatric manifestation is due to neurocysticercosis. This is another case report, which is anti-NAMDA. It's autoimmune encephalitis. Also, he presented with psychiatric symptoms and discovered to have a medical cause, autoimmune encephalitis. And I remember this patient very, very well because the patient has been discharged from many senior physicians. The neurology, they discharged him, the infectious diseases discharged him, and we were keen this patient to be seen by the medical team because the patient, I remember, was having like fever, one spike of fever, and the patient also was having confusion. Okay, so confusion and fever, you have to think about organic things. This is a new case. It's a case serious. We just released it recently. If you say it's October, 7th October. And this is about the hyponatremia. And hyponatremia as well, electrolyte disturbances, it can lead to seizure. Okay, and it's very important. Why we publish this paper? Because many people, when they talk about hyponatremia, they focus on the antidepressant, especially the SSRI. But we discovered that many medication, many antipsychotic, it can lead to hyponatremia, and you should give attention for this information. So the terminology is very important. There is a lot of change in the last release of the International League Against Epilepsy. They changed many names of all diagnoses. And if you go to the psychiatric book, you will find the old names. Even in my presentation, I use the old. But you know, partial seizure with secondary generalization become a focal with bilateral tonic-clonic, simple partial become a focal aware, psychomotor, dyscognitive become focal impaired awareness, grand mal become a generalized tonic-clonic, infantile spasm become epileptic spasm. And the chain that they took out, the loss of consciousness out, and they make, in spite of it, awareness, because they said that most of the description of epilepsies came from the lay people, and they don't know if the patient lost their consciousness or he didn't lose his consciousness, but they can know that the patient, if he is aware or unaware. Okay, so before I go, you have any question, anything? You want to ask anything? Or we are going good? Okay, if there is no question, I will go. Okay, psychiatric comorbidity. This is the main hub, and this is the main talk for today. Psychiatric comorbidity is very common in epilepsy. It's like 30–50% in newly diagnosed patient, and it can reach up to 70% with pharmacoresistant epilepsy. So when you have a patient with pharmacoresistant epilepsy, the likelihood of having psychiatric comorbidity, it can jump up to 70%. And it's not only psychiatric, it can lead to psychiatric, behavioral, and cognitive problem. Okay, this is Professor Besher. He wrote about Van Gogh in أصحاب هذا المرض. And he talked about Van Gogh. You know this? Anyone knows this paint? الصورة دي في واحد عارف اسمها شنو؟ ستار نايت. وفي نص كلامه ده اتكلم انه he was diagnosed as having bipolar. He was diagnosed as having also borderline personality. He was diagnosed as having OCD. Van Gogh has been admitted many times to the psychiatric service, and he died, I think, in 37 age. But he يعني رسم رسومات كثيرة جدا خلدت اسمه يعني. So this is from Professor Besher. So this is a psychiatric disorder. It's very difficult to cover all the psychiatric disorder in epilepsy, but my focus it will be on the main three, which is the depression and anxiety and psychosis, but definitely lead to personality change. Definitely it's affect the sexual dysfunction, and also it's affect the cognitive functions. Epilepsy, if it is not controlled, it can lead even to dementia, right? Major neurocognitive disorder, the new name. So if you see this picture, you'll find everything is duplicated when you have epilepsy, like a major depressive disorder, it will jump, and anxiety disorder, it will be double, mood and anxiety disorder will be double, suicidal ideation, even the suicidal ideation, it will be double. And this is the importance of addressing this comorbidity and offering treatment for these people. So what is the cause of behavior and psychiatric disturbance associated with epilepsy? Anyone from the residents, from the trainees, and say anything?
Again,
What is the cause? What do you think the cause? Why these people, they develop behavioral disturbance?
okay, maybe due to stress, due to dementia, especially in our country, because most of the patient may be stressed by community. والحاجة دي لاحظت عليها سبحان الله مع بروف بشر ذاته. أغلب العيانين بيجوا بعد مسافة فترة طويلة شديد، يعني الواحد بيكون مرات بعد ما يلف الشيوخ وكده، وطريقة التعامل بتاعتهم بتكون صعبة شديد، بيحبسوهم مرات، بيمنعوهم من اللحمة وهكذا، يعني traditionally. غير إنه الواحدة مثلا إذا في الشغل في أطفال في المدرسة بيطردوهم من المدرسة، والحاجة دي شفناها كتير جدا، بيقولوا إنه بعد وفي نساء بتطلقوا. المهم ففي ستريس شديد، ده السبب
صحيح.
الأول. السبب الثاني
ممتاز.
بالنسبة لي اللي هو maybe due to undiscovered change in the brain، يعني حاجة في البرين وهو the same organ undiscovered or brain structure not discovered، يعني حاجة كده ما discovered للآن.
صحيح.
فبالنسبة لي comorbidities. شكرا.
صحيح، يا سلام عليك، شكرا يا يوسف. طبعا انت لخصت الادفيرس سايكوسوشيال كونسيكونس. طبعا الاستجما بتخلي الناس يلجأوا للشيوخ قبل ما يمشوا للاطباء، مش كده؟ و they can spend long time before they diagnose, so they will have the negative consequence of the epilepsy. والCNS pathology absolutely right. طبعا هم بيعملوا MRI CT scan to discover if the patient has any change of the brain. Yes, this is, you will see it in my slide. The ictal seizure discharge itself, it can lead to behavioral disturbance. Anti-epileptic medication, it can lead to behavioral disturbance. So this is the common factors, that the ictal seizure discharge, the CNS pathology, the effect of anti-epileptic medication, the adverse of psychosocial consequence of having epilepsy. Okay, and you can add more. Okay, so psychosis. Let us start by psychosis. Did you any one of the residents saw any patient with post-ictal psychosis or interictal psychosis or ictal psychosis? Any volunteer? They call you for consultation for patient with epilepsy?
Good evening. I saw one patient. It was an interesting case actually. The patient used to have visual hallucinations at night. So it was
Yeah.
I don't remember the name of it, like internal induced epilepsy or something like that. But the patient used to wake up late at night, have
Hmm.
his visual hallucinations, and he was aware
Hmm.
of the hallucination. And then it was
Hmm.
actually a very, yani I was confused whether it was sleep disturbance kind of disease, or it was like temporary loop epilepsy, or what. So I
Yes.
requested an EEG for the patient, and it was actually positive. And then when I started him on Tegretol, on carbamazepine, I mean,
Hmm.
he improved, and يعني everything يعني went away, alhamdulillah. So it was interesting actually.
Yeah. Yeah. So the patient, and this is what يعني أساتذتنا كان بيعلمونا. Whenever you have olfactory hallucination or you have a visual hallucination, you have to think about organic. شكرا يا لبنى. Yes, it's very clear. بعدين البلايند ده ممكن يكون برضه something else يعني. Charles T. Point مش كده، ممكن يكون حاجة تانية برضه. لكن epilepsy is very common, and we are seeing a lot of patients, they came with complication. They came with frank psychosis due to the epilepsy. Okay. And this one has been discovered very early. Surprisingly, it's 1950s. People, they Hell and Bones, they talk about epilepsy. Okay. And what they describe, that they say these people, they don't have the lack of affect, they don't have the asocial, they are not withdrawn. They don't have the withdrawn attitude. So they don't have a negative symptoms. But most of them, they have the positive symptoms. Do you know when the first antipsychotics was discovered? If this was 1953, 1957, 1950s, the first antipsychotic. What is the first antipsychotic was discovered and when? Anyone volunteer?
أعتقد
Iman.
الكروموبرومازين.
Yes, chlorpromazine. Yes.
أوكي.
1953,
الفصل.
1954, right? So in the 50s,
Yes.
right? So before that, they talk about the psychiatric with psychosis with epilepsy. Okay. If you didn't focus in any slide and you focus in this slide, it's enough for me because will summarize the whole lecture. Okay. To know to classify the psychotic disorder with epilepsy. Okay. The epilepsy, it has three phases. It has the ictal phase, it has the post-ictal phase, and the inter-ictal phase and pre-ictal phase. Okay. Four steps. If it's expression of the seizure activity, during the seizure activity, we call it an ictal psychosis. If it is occurred within 7 days of the seizures or the seizure cluster, we call it a post-ictal psychosis. And by the way, the post-ictal psychosis have something called the lucid interval. The first day he could be okay, and the second day or the third day he might develop the post-ictal psychosis. The interictal, when it's occurred independently of the seizure, okay, so it's not related to the seizure. And this is very common, and usually it is long time, okay? We have the alternative psychosis, okay? This is the onset of psychotic symptoms followed the suppression of the seizure activity, okay? And some people, they think that few of epileptiform discharge, it can protect from the psychosis. And we have that when the patient is having severe depression, we took him to the ECT to give him shock, right? I remember very well there was a case presentation في المصحة وكان أستاذنا الدكتور عبد الغني موجود، ما عارف بيتذكر ولا لا. والبيشنت كانت she was very depressed وبعدين she developed a severe hypoglycemia. والsecond day she was improving. سألنا السؤال قال why this patient is improving. احنا ما كنا عارفين صراحه، لكن قال لانه البيشنت دي حصلت لها سيزر وبعد ذاك she become well. And the seizure was induced before by induced hypoglycemia. طبعا the old mechanism of ECT. Yeah? So it's very important. Sometimes the ECT, it can treat the psychosis, it can treat the depression for sure. So the ictal psychosis, like what Lubna say, it can be olfactory hallucination, it could be gustatory hallucination, it could be a visual hallucination. And when we have auditory hallucination, it will be poorly defined, like shapes, sounds, okay? and sometimes maybe complex visual scenes and speech. They can present with paranoia, they can present with grandiose thoughts, okay, but it's very rare to occur. And sometimes if you have a recurrent ictal psychosis, recurrent ictal attacks, like a silent seizures, and you present with a lot of psychotic symptoms, you might be diagnosed as having schizophrenia. So the EEG, it helps you. And the management of ictal psychosis is adequate seizure control. So once you control the seizure by giving the patient an antiepileptic drugs, the patient will be well, okay? And the differential diagnosis or the confirmation by EEG recording, okay? Am I going good or fast? Okay, the interictal psychosis, which is, it's very common, okay? Salter and Baird in 1963, they will noted that these patients are relative absence of premorbid personality. We know the prodrome, we know the patient, they have positive family history whenever the patient is psychotic or schizophrenia, okay? But those patients, they don't have a family history, they don't have a premorbid personality, and they have more positive psychotic symptoms. I remember very well, I was having an interictal psychosis patient. He's coming from Sudan, and he was having something in the mitochondria. He was taken like 5 anti-epileptic. So the first question, it was from the GP, when this patient will be discharged, because they were afraid that he will have severe epileptic attacks, or he can develop a pseudo. So it is very complicated. It is not an easy. So what is the predisposing factor for interictal psychosis? And it was typical in this patient that who came from Sudan. Complex partial seizure with secondary generalized tonic-clonic seizures. They have more auras. They have automatism. The epilepsy is long time, like 11, 15 years before the psychosis. So they have epilepsy, and then they end up with psychosis. Long interval of poorly controlled seizure. This patient is having 5 anti-epileptic. That means they try anything, okay? And the last resource was to combine this medication, because we don't like the polypharmacy, right? But there's a justification for the polypharmacy in this patient. Recently, diminution of seizure frequency. We know that we are giving ECT to treat the patient. Once we stop, the patient can develop. And this is why people, they talk about the small seizure discharge could be protective for the patient from the psychosis. Left temporal focus, mesobasal temporal lesion. And I remember very well also, I saw a patient with Prof. Abdul Aziz, and they reported was certain mesial sclerosis. سألنا Professor Hassan. He said this is typical for temporal loop epilepsy. Okay, whenever you find mesial. Okay, the post-ictal psychosis, it's very common as well. It has been described in the literature from antiquity in the 19th century, but it's still poor understood. So what is the common finding of the patient who are having post-ictal? Kanar, he make a summarize. There is a delay between the onset of psychotic symptoms and the time of the last seizures, which is, we call it, the delays is very important, okay? Lucid interval, relatively short duration of psychosis, because this post-ictal most probably it will not be long. Clustering of the symptoms into delusion and affective-like psychosis. Increased frequency of secondary generalized tonic-clonic seizure preceding the onset of post-ictal psychosis. The onset of post-ictal psychosis after long duration of epilepsy. So whenever you have, the more that you have a chronic epilepsy, resistant the medication, the more you will have a psychosis, okay? And they respond to small dose of benzodiazepine sometimes, or an antipsychotics. I remember that we give them clonazepam and they improve. Okay, so this they talk about the lucid interval. This is the SPECT study. In the SPECT study, revealed increased the cerebral blood flow in the mesial and frontal region during the psychosis. And this is the part that's going with the temporal loop epilepsy. And the volumetric neuroimaging study, they found thickening in restoral anterior cingulate of the cortex and the middle temporal gyrus. So this is associated with a okay, it's very common. They can call you for a patient. His seizure has been controlled. He was okay. The second or the third day, he develops psychosis. He becomes shouting, agitated in the ward. Okay, so you have to put in your mind one of the differential diagnosis patient might be a post-ictal psychosis. Okay, So this is very important, the force normalization. The concept of force normalization was proposed by Landoltz in 1953. If you see, all these studies are very old studies, okay? And patients, they develop psychosis at the EEG normalized. And this is why they theorize that they say that if having epileptiform activity could be a protective against psychosis in some individuals, okay? So in some individuals, okay. Yasser, I'm going good or I'm going fast?
You're going good.
Trainees, we are going good.
فاست شوية.
أي سؤال؟ ها؟ ماشي سريع؟
يلا كويس يا بوس.
تمام ممتاز. طيب depression studies, this is from the website, that 1 in 3 individuals diagnosed with epilepsy also have a depression. So depression is very common. And the problem of depression, it's unrecognized, untreated, undiagnosed. Why? Because the neurologist, he will focus on the controlling of the seizures. He will never ask the patient about his mood. He will never ask the patient about the functionality, because most of the time they just need this patient to be free of fits. Okay, so their main focus, it will be the patient to be free of fits. And this is why it's very important whenever you have a patient with epilepsy, especially chronic epilepsy, you have to ask about the mood. You have to ask about the functionality. You have to ask about the quality of life. And there is tools for diagnosis, okay? So Reportston, he has studies. He said that the mortality in epilepsy of suicide is 10 times more frequent than general population. And this is not an easy number. There is many patients, due to the poor control of seizures, due to negative consequence of the seizure, they might kill themselves. So it's very important to do risk assessment for any patient with epilepsy, okay? And the rate, he said that the rate could be higher if we focus on the temporal lobe epilepsy. So what is the pathogenic mechanism of depression in patient with epilepsy? PWE is the patient with epilepsy. So it is the same like depression. They have reduction in the volume in the frontal, temporal, the limbic region. They have also problem in the right hypocampus. Okay, it is smaller. The smaller the hypocampus, the more the patient will be depressed. Okay, and they have also problem in the serotonin receptors. Okay, and they have also hyperactivity of the cortisol level, HbA axis. So this is very common, and the depression is very common also in the patient with epilepsy. So it's not that much different, okay? Just to remind the people of the binding potential of hydroxytryptamine and for the receptors and for the high cortisol level, which is associated with the depression, okay? So the clinical manifestation, again, it's ictal, pre-ictal, and interictal, okay? So expression of the actual of the seizure, it's ictal. If it's occur pre-ictal, because there is many patients, they can have a depressed mood for maybe hours to days before they having the seizures, okay? And it could be an aura. All of a sudden, the patient become depressed, and then he develop a seizures, okay? If it is unrelated to the seizures, it's called the interictal. By the way, the interictal, the more cases we are seeing is the interictal, okay? The pre-ictal, the ictal, and the post-ictal, these are very rare to be catch up. But the interictal, usually it's come to our hospitals and they require treatment. What is the theory? Why people, they become depressed? Okay, the force normalization, because we are focusing to treat the patient. We are focusing to give the patient medication to control his seizure. So we approve the seizure, so the patient will become depressed. And we know the main indication of ECT is severe depression. Severe depression with psychotic feature, severe depression of refusal of feeding. We give the ECT and the patient will improve, right? Use of anti-epileptic medication. There is many anti-epileptic medication, they can lead to depression. And this is very important. And this is why we have to ask about depression. Like vigabatrin, 10%, tigapine, 5%, the phenobarbital also can lead, the Keppra, it can lead to like up to 2.5. So it is very important, again, to ask about depression. So ictal, depression, ictal, that means it is due to the seizure activity. okay? We know that psychiatric symptoms occur 25% of the aura of epilepsy is psychiatric symptoms, and 15% involving the affect and mood change. It is not a small number, right? So that it is big number, okay? Ictal depression. And ictal depression usually is brief, stereotyping, brief, okay? And it's occur without the context of environmental perception. So there is no stress, there is nothing, but the patient is feeling depressed, okay? And it's more common in the patient with temporal loop epilepsy. The patient, they present with sadness, they present with feeling pathological guilty, they present with hopelessness, and most of the time that they are not meeting the criteria of the DSM criteria. And at the same time, they are not like the dysthymia because the duration is different, okay? Pre-ictal depression. This is type of depression typically represent as dysphoric mood preceding the seizure. Before the seizure, the patient, he will become depressed, okay? Very depressed, okay? It could be 1 to 2 days prior to the seizure, okay? And the dangerous of this one, it can lead to suicide, okay? The post-ictal depression has been recognized for a very long time. It's very rare to find, but the patient, it's occurred after, most probably after the complex partial seizure, okay? And those patients, this happened due to the inhibitory mechanism and the termination of the seizure. Again, termination of the seizures, it can lead to the post-ictal depression because the patient was having a seizure, it was protective for him, his mood was okay, we stopped the seizure abruptly by the antidepressant, by the anti-epileptic, the patient, he developed the seizure, okay? So the interictal, which is very important, this is the one that we are catching a lot, okay? So these people, they present with a DSM criteria of depression, okay? But most of the time, they are not fulfilling the full criteria of depression. And it's always long time, and this is the one that required an antidepressant medication. This is very important take-home message for the depression. Depression is underdiagnosed, undertreated. Screening is very important. There's the PEC inventory for depression, the CSD, which is Center of Epidemiological Study of Depression. Before the treatment of depression, you have, prior to initiating the antidepressant, you have to check the plasma level of the anti-epileptic medications. Before the initiation of antidepressant, you have to consult the neurologist. You have to tell him that I will start this medication. It might affect the baseline of the seizure frequency. Choosing the antidepressant that does not affect the seizures, okay, and does not to have potential pharmacokinetic interaction. We know that many medication that from our medication, like the bupropion, if you go in a high dose, it can lead to seizure, right? So you have to be very careful. It will not be your choice. You can go for the medication like the SSRI, sertraline, or other medications. Okay, monitor the symptoms while you are treating depression is very important, okay? And we have the message that we have to screen the patient. We have to liaise with the other team before you starting your medication. Okay, clear? Okay. We are almost there. An anxiety in epilepsy, okay? An anxiety in epilepsy, the Canadian population, they said that it's 2.4 times higher with a patient with epilepsy. And this is very clear because the patient with epilepsy, they will be anxious. I will have the fit, I will not have the fit, I will have it in the road, I will have it in the school, I will have it in the university. They cannot drive their car. Sometimes they can take their license. So they have a lot of negative psychosocial consequences in their life, which can lead to an anxiety, okay? So this is why it is very common. What is the pathogenomic mechanism? We know whenever we talk about an anxiety, we have two important organs, which is the amygdala and the hippocampus. The amygdala, because it's a pathway for all the things. Okay, all the perceptions come from the amygdala. So and the amygdala is very adjacent to the hypothalamus. So when it's give you a signal that there is something dangerous, your sympathetic will be outflow, your body will be on fight or flight, okay? So you will have the fearfulness, you will have the palpitations, and other anxiety symptoms. And the hippocampus is like the recorders of re-experience of the symptom. So whenever we talk about an anxiety, we have to think about the amygdala, we have to think about the hippocampus. And also the GABA is very important. We know that the GABA is inhibitory for the brain, and this is why alcohol is working through the GABA. So when the GABA is not working, it will be taken over by what? When the GABA is not working, the trainees. GABA. When the GABA is not working in alcohol withdrawal. The upper hand for what?
Disinhibition?
Yeah. It will be for the glutamate, and the glutamate is excitatory for the brain, right? Yeah. And this is why we are giving, for detoxification for alcohol, we are giving GABA analog. We give the benzodiazepine because we want to prevent the seizures, because in the first 24 hours, the patient can present it with nausea, he can present it with an anxiety, the 40 hours he might develop a seizure, and 72 hours he might go to delirium tremens, right? So this is why we are giving benzodiazepine. So if you are giving for the patient, you will give him GABA analog, which is benzodiazepine. And we know the GABA analog also, it works very well in the anxiety. We know that we are initiating the benzodiazepine for the patient with anxiety for a short period before our medication kick off, right? So the GABA is very important than anxiety, and we use it, okay? As well, we use the GABA for controlling the seizure. So the main medication whenever you have a seizure is giving the patient diazepam, right? Before you go to the phenobarbital and the other things, you go to the diazepam. And in protocol, sometimes they put a Richter because sometimes it can be very difficult. You know, the diazepam, it should be, you have to have a vein, right? It's very painful when you give it gluteal, okay? And some people, they have a buccal benzodiazepine for the patient, okay? So it is very important. The anxiety is very important for the seizure as well. Okay,
دكتور
panic attack.
معلش سؤال
Yes.
ال
يا يوسف.
لو طبعا في السودان طبعا بيشتغلوا على حسب الموجود ما بالبروتوكول، لكن
نعم.
الانضمام متوفر. السؤال اللي بيجي
أيوه.
انه البنت عشان تجيه سيجرز عشان ياخذ لها ديزيبام ما بتكون فريكوينت كثير، وحتى الديزيبام ذاته الهاف لايف بتاعته ما طويله لدرجه انه الانزايتي تكون عنده كرونيك ديزيز. فالسؤال هل هو يعني هل الحاجه دي مثلا دوز ديبندنت، انه الديزيبام اذا الزول اخذه عدد كذا مره بيبقى عنده انزايتي، ولا ما دوز ديبندنت جست انت اديته وانس خلاص السايكل بتشتغل برا؟
هو طبعا شوف الدايزيبام، يعني انت دايما الديبندنسي the more the half time is short the more it will be dependent more. يعني انت عندك زي الزانكس دايما الديبندنسي بيكون اعلى من الدايزيبام، لانه الدايزيبام is long acting, it's not short acting. By the way, the chlorodiazepoxide is long acting, and we know that we are not giving the benzodiazepine for a long time. يعني usually we advise to be given like 1 week up to 2 weeks. That it will not do anything. So, and you give it for the patient with epilepsy, he need it because he have a problem in the GABA. So most probably he will not have any side effect of this one, and he will not be dependent from one dose. Okay, so we are using even the guidelines for the alcohol detoxification is using the long-acting benzodiazepine like diazepam or chlorodiazepoxide, okay, which is long-acting more than the diazepam. In Sudan, we don't have the chlorodiazepoxide, so why we use the diazepam? If the patient is having like a renal problem, you will go like safest medication like the lorazepam. Okay, but most of the time the detox regime it will finish like one week or 10 days it will finish. Okay, so we can give safely up to 2 weeks, and sometimes the patient they can't require the benzodiazepine to be given more time. We are not just following what is written in the books like 2 weeks. I remember very well I was with Professor Abdullah Abdurrahman, and there was one patient, he's 70s, and he came ask of lorazepam 2 milligram and 1 milligram. And I was sticking to the book. I told him that I will give you only two weeks. So when I go to Professor Abdullah Abdurrahman, he told me for how long he's getting this medication. I told him for a long time. He told me he's increasing the dose. قلت له لا. قال لي واي ليه حارمه يا مازن؟ يعني عايز تعمل لي ديتوكسيفيكيشن عمره 70 سنه هيكلف كم الدوله يعني. We have to be very smart in يعني prescribing our medication. we don't encourage people to use a lot of benzodiazepine for the patient because it's highly addictive, okay? But when we use the long-acting benzodiazepine, okay? For the anxiety, most of the problem, they use the lorazepam and Xanax more than the long-acting, okay? But it will be for short period. Is it clear?
Yes.
Yes, it does. طيب, panic attacks like fit. This is very important. And when I was reviewing the literature, I came to McNamara. He said that there is some panic disorder. They are not panic disorder. They are epilepsy. Okay, and this is very important. So I remember very well, Professor. And there is a paper that done by Professor Yahya Onallah when he was Al-Ain. Psychiatry is not a nice diagnosis. He calculate he make uh, analysis for all the patient coming by panic attack to the hospital, and he discovered many patients with panic attack, they are not panic attack. They have myasthenia gravis, they have epilepsy, they have genuine cardiac problem. So it is for exclusion. You have to do not lose your clinical cells. So you have to do proper examination for the patient, even if he has a panic attack or he's having conversion disorder. Give him his right, okay? You might miss an epilepsy due to the panic attack. So this is the ecternal anxiety and the panic attack, okay? So this is just a column. You will see the difference, like the ecternal anxiety is a short duration, 0.5 to 2 minutes. Panic attacks is 5 to 10 minutes, which is more longer. They have loss of consciousness, maybe go to the impairment in the ecternal anxiety. The panic attack people, they are alert most of the time. The ecternal anxiety, they have anticipatory anxiety, which can be more, okay? And the panic attack is very common. They are expecting they can have a deja vu. In the ecternal anxiety, very rare in the panic attacks. The automatism is very common on the patient with ecternal anxiety. It's very rare in the panic attacks. The interictal EEG often abnormal in the ecternal anxiety. You will not think to do an EEG for a patient with panic attack, right? Usually is normal in the panic attack. Ictal EEG usually abnormal and usually normal in the panic. Temporal loop MRI often abnormal. You can have a temporal tumor or anything. And in the panic attack, everything is clear. So this slide is also very important to differentiate between the ecternal anxiety and panic anxiety. And you have to put in your mind, panic attack not always is a panic attack. Okay, pre-ictal anxiety. There's some patient, they see the anxiety, they have an anxiety. They become very anxious most of the time. They are having fearfulness. It can last 2 hours to days. Okay, it could be an aura, it could be a prodrome of the ictal and anxiety. Ictal, we said that slide is very important. Fear and anxiety are fairly common in the ictal effect of the patient, especially in the temporal lobe epilepsy, because the discharge will be in the limbic system, okay? And the limbic system is the love system, right? So usually the sensation, anything is ictal, it will be short. So it's brief, lasting for only seconds and couples. When we talk about interictal, it is long, okay? The interictal anxiety, the anxiety syndrome appearing post occurring temporal lobe epilepsy and generalized epilepsy. Patient report experience. They can have a different range of feeling of the DSM criteria. Panic disorder, they can have generalized anxiety, they can have obsessive compulsive disorder. There is many theses, by the way, في المجلس اتعملت عن epilepsy and OCD. I think Dr. Mukrim, he did one about the OCD and epilepsy. And it is very common, okay, interictal anxiety. Okay, what is the management? This is almost the last slide, Yasir. I think I will finish on the time. Okay, so the management of an anxiety in epilepsy, first, improvement of the seizure control by appropriate measure has been recently shown to reduce the anxiety level. is يعني انت عالجت الابليبسي معناها عالجت الانكزايتي. Benzodiazepine are obviously attractive choice due to their potent anti-epileptic and anti-anxiety. Okay. Alternative one might be used the bisporone, partial agonist serotonin receptors, and the SSRI also are very safe. The second issue regarding the anti-epileptic choice of the patient with epilepsy and anxiety, pregabalin and gabapentin could be used, and the CBT is very important also for treatment of the anxiety. Conclusion, okay, for what I said, all the patients with epilepsy should be routinely screened for psychotic disorder at the onset and at least every year. Patients with epilepsy and their relatives should be informed about the risk of mental health problem and the complication. Physician must identify the comorbid psychotic disorder and incorporate them into the comprehensive individual management. Okay. Anybody knows who is this? Trainees?
فان جوخ.
فان جوخ. يس يس. وفان جوخ طبعا اتوفى عمره 37 سنة افتكر. وشوف يعني اتولد في 1800 وحاجة، لحد الآن لوحاته مخلدة. يعني ده بوريك إنه المرض النفسي ما بيمنع الإبداع، مش كده؟ هخليكم في بعض الصور لفان جو. دي بعض أعمال فان جو أختم بها. شكرا يا ياسر. وأنا بيدي أكون ختمت المحاضرة. لو في أي سؤال.
شكرا جزيلا مازن، والله محاضرة يعني روعة في ساعة واحدة. حاولت انك تلم الموضوع كله يعني تسكس various aspects of epilepsy في psychiatric disorders. لو افتكر كان في حبة أسئلة في نص المحاضرة، يعني افتكر في سؤال انا افتكر ارجع عليه دقيقة.
جدا.
يعني سؤال كان في نص المحاضرة اللي هو the psychotic بن محمد إبراهيم the psychotic symptoms differ from one ictal attack to another ictal attack for the same patient.
طبعا ما في signature طبعا. It could be different. Yes, absolutely. Could be different يا ياسر. There is no signature.
أي زول عنده سؤال ممكن يرفع يده طوالي يخش يشارك، يقول اسمه يشارك.
السلام عليكم.
وعليكم السلام ورحمة الله. تفضل ياسر.
دكتور حمد ده.
شكرا جزيلا.
حمد. دكتور حمد، ازيك؟ كيف حالك؟ الله يحفظك.
تفضل
الله
دكتور.
يحفظك دكتور حمد.
دكتور حمد عندك إضافة، صوتك راح ما سامعينك.
ما سامعني؟
لا ما سامعينك، عندك
تفضل
سؤال
أستاذنا الكريم، تفضل.
بقول انه الموضوع الابيليبسي هو موضوع مشترك بين البيدياتريشن والميديكال سبيشاليست والسايكاتريست. كل الثلاثه تخصصات دي كلهم بيعالجوا ابيليبتيك بيشنتس. انا اذكر لما كنت شغال في السعوديه في الطائف، كان عندنا عياده بتاعت ابيليبسي. فالاداره قررت بانه المرضى الابيليبسي ديل المفروض يشوفوا النيورولوجيست، واحنا كسايكاتريك هوسبيتال ما عندنا معاهم قضيه يعني. فبدينا تو ريفيرزم تو جنرال ميديكال هوسبيتال، ويمكن ما عندنا شهر شهرين جابوه لنا راجعين معظم كلهم. قالوا يا اخي ديل معظمهم عندهم سايكاتريك بروبلمز وعاملين لهم مشاكل هناك وما قادرين يستحملوهم. فاول
نعم
شيء ازرور طبعا اي بيشنت نفرق بين السيزر وبين الابيليبسي. الابيليبسي حاجه ريكرنت يعني،
نعم
لكن احنا كلنا
صحيح
متفقين فيرست ابيسود بتاع السيزر ده شود بي ريفير، ده اصلا ما تبعنا، امشي لنيورولوجيت. فده
نعم
متفق عليها. الحاجه اللي عايز اضيفها برضو انه حكايه الاي سي تي والابيليبسي. طبعا الاي سي تي
نعم
تعتبر انتي ابيليبتيك، لانه مع كل الابلكيشن بتاع السيزر، السيزر ستيل
absolute
شو.
right صح صحيح
فدي الناس
بتزيد
يعني sometimes في الانتراكتابل سيزر اي سي تي از انديكيتد.
نعم
الحاجه
absolutely
اللي
right
عشان ما اتكلم معاهم ما اطول، الحاجه الاخيره we have to be updated في التريتمنت على النفسي. This is very important يا
نعم
جماعه. This is very important. كل فتره والثانيه البوليسي بتتغير، ف we have to be updated.
نعم
يعني ما انا يعني الفيرست لاين بتاعت الابيليبسي مثلا جراند مال زمان اللامتراجين ده ولا كان فيه له اي ذكر، حاليا بقى فيرست لاين. ده كمثال يعني.
نعم صح
فدي نقطه مهمه.
والناس المفروض تمشي تقرا عن الانترناشونال ليج اجينست ابيليبسي، يعني دائما
كل فتره
بيكون فيه
والثانيه.
انفورميشن جديده وابديتد، مش كده؟
نعم يعني.
ايوه
ايوه. فالدراسات
صحيح
بتتعمل والبوليسي بتتغير. النقطة الأخيرة
صحيح
حكاية التمبرال لوب أو البارشال كومبلكس سيزر التمبرال لوب إبيليبسي. يا أخوانا دي كمان للأسف it is being missed by so many doctors. كثير من المرضى
نعم
بيجون شافوا دكاترة كثيرين، فبتلقى البيشنت عنده بارشال كومبلكس سيزر أو تمبرال لوب سيزر وحاجة تريتبل. والطب ده أسوأ
صحيح
حاجة أنك تمس مرض تريتبل. وشكرا جزيلا.
نعم نعم شكرا دكتور حمد، اضافه جميله ومهمه جدا جدا.
السلام عليكم.
وعليكم السلام ورحمه الله.
كيف الحال دكتور؟ محاضرة أول شيء جميلة جدا، وبجد يعني قلت كلام كتير شديد استفدنا منه. أنا مريم
الله
غازي.
يحفظك.
بس كنت عايزة أعرف، لأنه زي ما أنت قلت في كلامك، يعني إنه الإبيليبسي لما يكون for a long time أحيانا، والأنتي إبيليبتيك ميديكيشن الاثنين مع بعض بيجونا ممكن بسايكوزيس أو مثلا behavioral disturbance أو كده. طيب والانتي سايكوتكس لو احنا عايزين ندي البيشنت يعني كخيار نديه انتي سايكوتكس، الانتي سايكوتكس برضه هي بتعمل يعني it will lower the threshold للسيجرز يعني.
صحيح صحيح
فممكن يكون
absolutely right.
الحل شنو؟
طبعا شوفي يا دكتورة مريم، طبعا انت you have to weigh things، يعني توزن الامور which is have the upper hand if he's the main problem is his psychiatric disorder. نحن دائما لما ندي حاجة فيها organic بنحاول ندي the minimum dose that can control the symptoms، وبنشوف the safest medication. Usually we go to the guidelines، يعني طبعا زي الريسبيريدون مثلا it is very safe in the epilepsy، لكن usually we go with the lowest dose. يعني I will try to avoid the clozapine مثلا. clozapine in high dose per se it can lead to epilepsy, it can lead to seizure sorry. البروبيوم في الانتيديبريسنت by hard dose it can lead to epilepsy. So I will go to the safest medication in the lowest dose that can control the symptoms. Well, very important also I have to do psychosocial intervention. يعني I can refer the patient for therapist if he is depressed. I can see what is the problems. I can discuss. عشان كده أنا لما اتكلمت في الدبريشن قلت you have to discuss with your neurologist وتشوف الميديكيشن ذات اللي بياخدها البيشنت. هل الميديكيشن دي one of the side effect of it is it can provoke the psychosis, it can provoke the anxiety. So you have it is teamwork. You have to make a teamwork for the epilepsy. زي ما قال دكتور حمد العيادة should be multidisciplinary team. It's not one man show. إن شاء الله تكون واضحة بالنسبة لك الإجابة دكتورة مريم.
ايوه ايوه واضحة، شكرا جزيلا.
الله يحفظك، سؤال مهم. الله يحفظك يا رب.
انا في حاجه اضيف وقت ما في حد كان في واحد عنده سؤال. ساعات يعني we're not talking about complete epilepsy ولا حتى complete seizures. في حاجات زي prodrome للسيجرز ذاتها زي المايكلونس مايكلونيك
نعم
جيرز دي قاعد تحصل ساعات
yes
من medications as يعني لما it reduce the seizure threshold. and I've seen this occasionally sometimes with clozapine. تدي clozapine بعدين فجأة بتلقى العيان
yes
في اليونت ولا في الورد وفجأة كده فهمت
نعم
suddenly كده.
وقع مرة.
وبعدين
صحيح
بعدين لما الوقعه ذاته لما يكونوا ماشيين suddenly بتحصل في الفوت وفي الرايت سايد مثلا كده يعني بتبقى جيرك
exactly
suddenly
exactly
تمشي
yes
تعمل
yes
اي
exactly
بتلقى ليك حبه سبايكس قاعده مثلا تقريبا في الاوكسيبيتال لوب depending on what medication. الحاجات دي ساعات
يا
بتكون additive effect ذاته، يعني ما بالضروره انه يكون انتي سايكوتيك. ساعات في ميديكيشنز لما تضيفهم مع بعض الاثنين مع بعض يزيدوا. الليثيوم كان دو ذس، سم انتي سايكوتيك
يس
ما كلهم كان دو ذس. فدي حاجات ما بالضروره انها فول بلون behavioral changes, just some motor changes.
absolutely right. well said.
عبد العظيم تفضل.
دكتور عبد العظيم تفضل.
شكرا جزيلا، شكرا يا مازن. والله يعني يعني Father is very good lecture, very informative.
الله
It's just
يحفظك.
my question, because we usually knows, I think from the scientific fact that usually when a patient is under medication and epilepsy is controlled, I think about 3 years they will most patients, I don't know what is the percentage, but
They will
most
stop.
patients
Yes.
they will stop, yeah, and
Yes.
the seizure will stop also, isn't it? They will be cured.
Yeah.
With
Yeah.
if they
Yeah.
have a, yeah, if this
Mm.
kind of patient, are they still likely to have psychiatric complications or psychiatric illnesses? Or is it,
They can have.
or this psychiatric complication usually happen when the epilepsy is active, or is it, yeah?
والله يا عظمة ممكن تكون طبعا الابيليبسي، وممكن تكون a negative consequence of the psychosocial life. يعني at the end اللي بيخلينا نقرر ان احنا to stop our medication the follow up of the patient. عشان كده لو لاحظت انا في الريكومنديشن قلت البيشنت should be assessed at least twice a year. يعني يجي البيشنت وتعمل له سكيلز وتشوف هل البيشنت is truly psychotic ولا he is truly depression. في النهايه نحن we are treating the symptoms، يعني we treat the patient. يعني if the patient is still symptomatic, is still having in spite of stop the antiepileptic, he is depressed, I have to give him definitely the antidepressant. لكن لو مثلا the seizure has been controlled his mood is controlled and he has adequate time on the antipsychotic, I can give him a time طبعا to be free يعني of medication.
Okay, yeah. Thank you.
لحد السؤال الجاي يا جماعه ما تنسوا السيرفي خطيته في الشات. دكتور عبد الغني.
مهم يا اخوان السيرفي. دكتور عبد الغني تفضل.
السلام عليكم ورحمة الله للمرة الثانية. شكرا مازن، very informative presentation، وشكرا للمتداخلين. لكن كنت أتوقع أسئلة أكثر من أبنائنا وبناتنا الترينيز. ودائما بقول لهم أسألوا قبل أن تسألوا. أسألوا قبل أن تسألوا. ما سؤال الآخرة، سؤال الدنيا. سؤال الآخرة. طيب أنا عايز أسأل الترينيز عن الميديكال ليجال aspects of epilepsy. It is out of the scope of the lecture، لكن ما دام جبنا الإبليبسي نسألهم عن الميديكال ليجال aspects of epilepsy. يلا يا شباب.
طيب أنا ممكن أشارك؟
واحد يتكلم ويقول اسمه.
يوسف افتكر.
اوكي، السلام عليكم. بالنسبة للميديكوليجال اسبيكت اوف ابيليبسي، انا يوسف فضل الله. بالنسبة للميديكوليجال اسبيكت اوف ابيليبسي، ودي كيسز كان برضو مرت علينا، انه هو البوست اكتل كونفيوجن ستيت، اللي هي دائما بيكون البيشن ما واعي، خصوصا الالدرلي والناس اللي عندهم structural disease بيكونوا ما واعي، فبتصدر منه بعض الاشياء، حاجات الناس بتشوفها بحكم الوعي. معلش ما بقدر اصيغها بالانجليزي كويس، لكن تصدر منه حاجات او اكشنز بيكون زي حكم الوعي. مثلا ممكن يطلق مرته، ممكن يقتل زول، ممكن يعني يعمل حاجة زي دي. فضروري انه البيشنت واهله يكونوا عارفين الحاجة دي، ويكونوا عارفين انه الموضوع ده ممكن يستمر من ساعات الى ايام عديد، ويكونوا عارفين الحاجة دي، ويكونوا يعني عشان تبي شور انه ما تحصل حاجة زي دي. برضو التمبرال لوب بيبسي بتكون مرتبطة ب behavioral change، قد الناس ما تكون منتبهة لها. شكرا.
شكرا لك، وشكرا لرحاب برضو. نحن عارفين انه الابليبتيك اوتوماتيزم sometimes during automatism epileptic patients can they can kill, they can do murders كمان. وفي دراما افلام عن الابليبتيك اوتوماتيزم فيلم شهيد جدا بس ما قادر يتذكره. لو تتذكروا يا مازن ولا عظمة ولا ياسر. البيشنت during epileptic automatism قتل his in-laws, his father-in-law, his mother-in-law، وجا نام تاني في البيت وما بيتذكر الحكاية دي. فإف الاتورني ولا السوليسيتر could prove a diagnosis of epileptic automatism, this is can change الفيرديكت diminished responsibility ولا whatever it is. دي حاجة ثاني معناها. وزي ما قال يوسف اللي هي disturbed behavior, abnormal behavior, disinhibition، حاجات زي دي كلها can be يعني minor offenses برضو medical legal. Epilepsy, epileptic patients and driving. Epileptic patients and driving. نمنعهم ما يسوقوا طول حياتهم. نعم الاجريشن قلنا اي disturbed behavior بيكون مع هناك. دي حسب legislations of the countries. In Sudan 2 years free of seizures بالضبط يا سحر، كتبها تحسي سحر وكتبها احمد شريف برضه. 2 years free of fits they can allow to drive again. فلازم ندي اعتبار للميديكو ليجال اسبكتس دي يا اخوانا، لانه الستيغما زي ما قال مازن ما بس على السايكايتري. الابليبتيك epilepsy is a stigmatized disorder.
Yes.
Thank you. شكرا مازن.
الله يحفظك. شكرا استاذ دكتور عبد الغني، شكرا على المداخله الجميله.
أي سؤال ولا أي مداخلة تاني؟ ما في حاجة. حقفل الفيديو. طيب حقفل التسجيل، لكن لحد الآن المشاركات في